Thank you. Well, it's a real honor to be here, and I hope you caught that from Dr. McLean, that I started out here. And so I wouldn't be where I am today if Craig hadn't said, you should study fatty liver in kids, when I was I think a third-year resident, so a long time ago. Okay, so Matt asked me to talk about pediatric steatohepatitis mechanisms and environmental exposures. And I have to confess that I took a little liberty with this, and I'm actually going to talk about pediatric steatohepatitis and one important environmental exposure that I've been studying since my time here in Louisville. So one of the things I hope to convince you of is that pediatric NASH and NAFLD is a very important problem, and not only just in the United States, but worldwide. And if you look at this picture here, you can see that the prevalence is not only increased in the United States, but it's also very high in Mexico, in some European countries, in China, and in Japan. These are screening studies that used ultrasound or liver enzymes in obese adolescents. And if you look at these prevalences, they're incredible. I mean, 50% and 70%. So this is not just a handful of kids, and this is a problem that could grow in its importance over the next generations. So we looked at the prevalence of fatty liver disease in the United States and tried to see if it was increasing or if this was just something that we hadn't really looked at carefully 10 or 20 years ago. And this is NHANES data, and it goes back to the 88 to 94 NHANES, and then over the next 3 cycles to the 2007 and 2010 on the right-hand side here. And we looked at the data using both ALT from the kind of older cutoff of 30, and then, of 30 on this line, and then also using a newer cutoff that's gender specific. But the important part is the trajectory of these two curves. You can see that it's more than doubled in prevalence over these years. And not only has it doubled, it's actually still increasing, even though childhood obesity has now flattened out. So it may be that there's something that's continuing to cause more pediatric fatty liver disease, even though obesity seems to have settled out in its rise. So what are some other variations in fatty liver disease? It happens in boys much more than girls. And this is particularly interesting. Craig and I were talking yesterday. The animal models that you see, the diet models, are in male mice. And there's almost no studies, apparently, that have female mice included. And so this is also a little bit true in the human data. You can see here that the boys are it's much more common in boys compared to girls. There's also race and ethnic variations that I think probably speak to pathophysiology. So the Hispanic kids get it much more commonly compared to non-Hispanic white, compared to non-Hispanic black. The Asians, there wasn't enough data on that population in this study, but they kind of fall between Hispanic and white. And then one more comment on prevalence, because I think this is another really interesting fact, and I'll show you some more slides on it. But it really doesn't happen in young kids. So even if a 3-year-old gets super obese, they don't get fatty liver. It happens a little bit later. And so when we see it clinically present to somewhere around 10 or 11 years of age, and this particular data set that I'm showing you here is a nice one because it's independent of referral. So this is data from an autopsy-based study where they collected the livers from 10 years of traumatic and accidental deaths in children. And they found that there was fatty liver present in the older kids, but you can see in the 2 to 4-year-olds almost nothing, and then just a few cases in the 5 to 9 years old. And actually probably that 5 to 9-year-old bar is mostly represented by the 9-year-olds. So you heard a comment that I think it was Matt that said it, that one of the things that's interesting is that in the adults, the bariatric surgery patients don't have a lot of fibrosis and not a lot of NASH. Well, that's true in the adults, but it's not so true in children. And so it may be that pediatric fatty liver disease is much more severe than adult. And so it's a little bit hard to compare those when you just look at clinical cohorts, so people coming to the office usually have higher liver numbers, so you get a lot of referral bias in those collections of data. So I thought this was a really good study because there was no referral bias. In this study, they compared adolescents who were undergoing bariatric surgery to adults who were undergoing bariatric surgery, and they had 24 in each cohort. And you can see that the average BMI was similar between both groups. Now, presumably the adults have had the disease longer, but if you look at the number who had NASH, there were many more in the pediatric cohort, 62 compared to 25. Similarly, with the fibrosis, 83 compared to 29. So, you know, it's hard to know because this is a small study, but it hints at this, what we see in pediatrics is that this is not a mild disease we're seeing. These are not people and kids who are going to go on to 55 before they have their liver transplant. And this is a case report by some of my colleagues in Cincinnati, but it shows you this progression of fibrosis that happens in children. And I see this commonly in my clinic. I tend to repeat their liver biopsy at the 3 to 5 year mark after their first biopsy, if they've had NASH on the first one. And it's very common to see this kind of progression in the fibrosis. So you can only imagine where this is going. So I've told you a little bit about age and gender and ethnicity. There are many factors that probably influence this disease, and one of the things that I think has been beautifully covered is how important the genetics and microbiome, the microbiome it modifies those first effects, and then those lead to the phenotype of NAFLD and NASH and normal. But I also want to point out that this is not just a liver disease, and it may be one of the tricky things about studying it in animal models is because, and in cell models, because it's really a whole body problem. So the kids who come to see me and the patients with this disease, they don't just have fatty liver. They also have dyslipidemia. They have insulin resistance. They're getting type 2 diabetes. They have atherosclerosis. So it's important that when we're studying it, we're looking at something that looks at all of those features. And, you know, there's new medications that are being studied right now, and some of them might improve the inflammation in the liver but make your dyslipidemia worse. Well, stroke and heart attack is actually the #1 reason why people die from fatty liver. So do you really want to take a drug that would improve your liver but kill you off sooner? Right? Okay. So what are some of the fundamental questions that I want to try to speak to a little bit? I think these remain unanswered, but there's some new data coming out. So what is the age of onset, and why is there this interesting sort of change there? Why is it so severe in childhood, and what causes it? Well, we can't really solve what causes it, so what contributes to the disease? So I told you that very few children are diagnosed before the age of 10, and this is some of the data from my own clinical practice. We have some research studies where we're collecting liver biopsies from children who undergo those at our center. And I just thought it was interesting to look. You can see the peak is really 11-year-olds who get biopsied in our practice. And then there's many in the older teenage years, but there were none before age 9. And I'd say since we collected this data, it's changed. I've had a couple 8-year-olds who got biopsied and did have NASH, but this is pretty common that it's this older age. There's been very few studies looking for fatty liver in 6, 7, 8-year-olds, and so it's a little hard to know if it's just a silent disease or if it's actually not there. But this was one study that was done in 123 8-year-olds using MRS, which is magnetic resonance spectroscopy, and they found just a little bit more fat in the obese group compared to the normal group, but it was 1.5% fat. And generally we define NAFLD as 5% fat or greater, so there was basically no NAFLD in this cohort. Importantly, though, remember I told you that Hispanics get it more than other groups? They only had 4 Hispanics in this particular cohort. So I think this needs to be studied further. One of the reasons why it might start in that kind of age group of 9 to 11 is because of puberty. And this is a nice schematic showing the insulin resistance that rises normally with puberty. And if you're obese and going through puberty, you have a much greater rise in insulin resistance. And so it might be a time where the child is particularly kind of set up to develop the disease. They may cross a threshold that wouldn't have been there otherwise. Okay, so what are some of the reasons, possible reasons, why this might be so severe in today's children? Well, I think, as was mentioned, the maternal influences might be influencing this. And there's been multiple mice studies where they've fed the maternal rats and then looked at the offspring. And I'm presenting this one. It just happens to be one of the newer ones that has a particularly pretty picture, so I thought you all would like that. So in this study, what they did is they fed mice the high-fat diet, and then they looked at the offspring, and they fed the offspring both the control diet and the high-fat diet. And you can see here in the bottom right-hand corner that this is where both the mother and the child got this Western diet, And you can see here that not only is the liver huge compared to the other ones where it was the regular control diet and mother-child, and then the one where it was the mother and then the child had a normal diet. So here is the double whammy, so the double hit. And they have not only just fat in the liver, but they had steatohepatitis. They also had increased de novo lipogenesis, increased inflammation, and you can see here a measurement of the liver weight and how much it was increased. So does this happen in humans? Well, unfortunately, mice are not that similar to humans, so it's nice to have animal models that are a little bit closer. But you can't really do this to people, so this was a group who tackled it in monkeys, which I think was a really good idea. So they set their experiment up just a little bit differently, and the white bars are the offspring getting a control diet, and the black bars are the offspring getting the high-fat diet. And so that's the first set, and the mother's got control diet. Here is the mother's getting a high-fat diet, but then they remained insulin sensitive. And then they divided out a third group where the mother's got the high-fat diet, but the mothers became insulin resistant. Okay, so what did they see? Well, basically, when the mother's insulin resistant, the offspring have fatty liver. And so that fits well with the rodent data and is worrisome because here they're showing you the biopsies of the juveniles, and these are the juveniles who got regular healthy diet. So it actually predisposed the children to disease even if they were on a good diet, if the mother was on a bad diet and insulin resistant during the gestation. So I think that's very worrisome for our children today, given what we know about the maternal diet and many moms being insulin resistant. So I told you there's not much human data, but I thought this was a very interesting new study that just came out. So they looked at stillborns who were born to moms who were diabetic and pre-diabetic, and they compared them to stillborns for moms who were not. So looking at that same sort of insulin resistance during gestation that the monkey study I just showed you did. And this is incredible. They found fatty liver in 78% of the stillborns from the diabetic mothers. So while I don't know what happens after this, if this fatty liver persists, because people aren't evaluating 2-year-olds, 3-year-olds, 4-year-olds from this situation, these children may be set up that then they're the ones who are going on to get disease when they're 10, 11, 12. Notably, the steatosis was also more severe in the diabetic cases, and there was no correlation to maternal BMI. So it wasn't just what the mother weighed, it was really the setting of prediabetes and diabetes. Okay. I told you I was going to talk a little bit about environmental exposures, and really I'm going to talk about one that I've been studying for a while. And since I came from this group, you can imagine it's probably fructose. And there's been a huge change in the exposure level of fructose in the population. I like this graph because it really shows you the change over the last 200 years rather than kind of looking at the last 20, 30 years. And you can see here on the left-hand side, from 1700 to the 2000 mark, there's been a dramatic increase in all sugars. So this is not just high fructose corn syrup going up in our society, but we really changed the availability of sugar for the entire population. This is my quiz question, so if anybody's heard this before, don't answer. It's only for people who've not heard the question. All right, so what are the two dips? Yes, World War I and II. So this means that government restriction really does work. So we need to support the New York governor's efforts. All right. That was my only political comment, right? You're not really supposed to go into politics up here. All right, so we were very interested in this, and I had come from a group that did beautiful animal work. At Emory, we actually I did a few more animal studies before switching over to what I'm going to show you next. And Dean's smiling because he's my mentor at Emory. But you know what? This is really tricky because if you feed rats, we switched to rats. If you feed rats fructose long enough, they adapt and the fatty liver goes away. So always sack your animals before Christmas break, not after. Right? Lessons. So, and just other difficulties like that. The microbiome is different from lab to lab, so nutrition models in animals can change when you move centers, so it was a real challenge. So we switched to kids because that was so much easier, because you can't get their blood, they won't consent, they don't show up for the studies, so pediatric studies. So we decided to look at fructose in children and compare it to glucose. And so this was one of the first studies that I did at Emory, where we brought in children who had fatty liver disease, and we actually had a whole control set of kids as well. And we brought them into the inpatient unit for 2 different days, and on one of the days we fed them breakfast, lunch, and dinner, and we gave them a glucose drink, which was the control, and on the other day we gave them breakfast, lunch, and dinner, and we gave them a fructose drink. So here's the data. So here's breakfast, lunch, and dinner, and here's the 24-hour study. And then the fructose is the top line, and the glucose is this bottom line. And this is triglycerides going up the side. And first of all, you'll note that these kids have sky-high triglycerides. These are children with fatty liver disease, so normal should be down here by 60. If you're fasting. And so they already have elevated triglycerides to start. And then when you give them fructose, the fructose goes up markedly. But one of the interesting things about this data is that it was really variable subject to subject. So this bottom graph is that same group. So here's the nice pretty means for the published paper. Here is the individual data from this breakfast, lunch, dinner across the 24 hours. And you can see some subjects have a very poor ability to control their triglycerides, to keep their triglycerides within those normal levels. So some have really poor ability, and some, even though they have fatty liver, like this little red dotted line, really still controlled it and looked more like normal. This above was the normal group. And so they still have some rise in triglyceride after fructose, but they don't have nearly as much. They keep it within a better range, so instead of going so high. So what happens if you do this longer? And this is adult data from Kimber Stanhope and Peter Havel's group. And on the left-hand side is the glucose-fed folks. And they looked at it at 0 weeks, 2 weeks, 8 weeks, 10 weeks. And then on the right-hand side is the data from the fructose group. And there, again, they're looking at it over the same time period. And I'll blow up that second graph for you so you can see it a little bit better. But basically, by the time you reach 2 weeks, the effect is there. So they've been fed this for 10 weeks, and then they brought them in and did a very similar experiment that, as I just showed you in the kids, where they had breakfast, lunch, and dinner, and then look at them over 24 hours. And you can see that there's not an adaptation. So at least by 10 weeks, they're still having an effect from the fructose that's very different than the control. They also looked at visceral adipose tissue in these same individuals, and remember I told you visceral fat and fatty liver are very tightly connected, and so the visceral fat in the fructose-fed group over 12 weeks went up dramatically compared to the glucose group, and I highlighted those in green for you. So 10 weeks seems to have effect. What if you go longer? And I don't know of a very tightly controlled experiment like I just showed you that lasted 6 months, but this is a 6-month beverage study that was done in Europe where they looked at cola, and so this is actually sugar, it's not high fructose corn syrup. And then they looked at milk compared to Diet Cola and water. So people were randomized to one of these beverages. And it is interesting how they set it up because it's always tricky how you control it. So this is regular cola to Diet Cola is the sweet control. Milk is the caloric control to the cola, and then water is sort of water best control. And you can see that the change in visceral fat again was quite impressive. And they also saw a dramatic increase in hepatic fat, here shown in this black bar. One of the things that this paper didn't report, and I was a little bit disappointed by that, is they didn't tell the absolute value of hepatic fat. And of course, going from like 1 to 1.5 wouldn't be that impressive or exciting, but they did see a change. So I don't know of any good long-term studies that show a decrease in hepatic fat with just decreasing sugar, but there was this study where they decreased carbs, and often a low-carb approach or a low glycemic index approach also decreases sugar. And so here, when they compared a low-carb diet to a low-calorie diet over 2 weeks, there was a nice decrease in hepatic fat. So that's somewhat suggestive that there may be an improvement versus an increase. One of the reasons why there may be so much variability in individuals' responses to sugar studies is that, like I showed you in our data, is because of the interaction of genetics and sugar. And one of the genetic polymorphisms that's associated with fatty liver is PNPLA3. And Michael Gorin in California looked at a group of Hispanic adolescents, and the Hispanics have a very high prevalence of this particular polymorphism. And he didn't see an effect with just sugar and hepatic fat, or an effect with just PNPLA3 and hepatic fat. But when you combine the two, so they had a high dietary history of sugar consumption plus the polymorphism, those were the ones who had the hepatic fat. So it speaks to this multifactorial version of this disease. So the last study that we did that I'm going to describe for you is our fructose reduction study. So I told you that there's not really good sugar studies where you take away the sugar or take away the fructose and try to see if the fat gets better. So we set out to do that. And we set this up as a randomized controlled trial. Here we enrolled 24 subjects. They were split between the glucose beverages and the fructose beverages. We had some dropout, and so the groups were did decrease, so we lost to follow-up 1 on the glucose side. We lost several to follow-up on the fructose side. And then, so the final analysis was 12 compared to 9. We did do all of the analyses as an intention to treat, and so all the data I'll show you is based on the subjects who completed, but there were no statistical differences when you did an intention to treat. It included everyone. So these were the baseline characteristics, and so you can see they're right in that age group that is pretty typical for fatty liver disease, so 14 and 13 in both groups. These were randomized, so I'm not showing the p-values because they should be equal based on randomization, but I will also tell you that all the p-values were non-significant. A little bit more male in the glucose group. The body weights were pretty similar, BMIs were pretty similar, and then hepatic fat was 14% in both groups, so nicely matched for a primary outcome of hepatic fat. So what happened? So what we did is they they were either drinking a glucose drink for 4 weeks, and it was 3 little bottles of looked like just like a sugar drink, and they were identical, so in appearance, so people couldn't tell which one they were on. And then, so that was the glucose ones. And then the fructose ones had a very similar drink, looked the same, but it had fructose in it. And it had about 33 grams of sugar, each one did. So it's very similar to what a soda might have. So I'll first show you some of this data. This is CRP, and this is after the 4 weeks. And you can see that inflammation went up significantly in the fructose group, but slightly improved or didn't change in the glucose group. And the adipose insulin resistance also went up in that fructose group. And I'm showing you the adipose insulin resistance because HOMA-IR, which is another marker of insulin resistance, didn't change much. But adipose insulin resistance is combining the free fatty acid level with the insulin level. So it really looks more at peripheral or the fat insulin response. And that's more, it's changed more in kids with fatty liver disease, and it correlates better with the amount of fat in the liver compared to HOMA-IR. So we saw a significant change in that, which I think is very important for the liver over time. Lastly, we saw a big change in peripheral dyslipidemia. So the triglycerides went up, and the size of the VLDL particles, which carry most of the triglyceride around the bloodstream, those went up significantly in the fructose group. But I'll tell you, it was a negative study because we did not see a difference in hepatic fat. And so here's hepatic fat in the top green arrow there across, and I wanted to show you all the numbers, but it basically just stays the same. So at baseline 14.5% in the fructose group, going to 13.6%, and then same in the glucose group, 14 and 13.8. So really no changes at all there. Free fatty acids, which was reflected in the adipose-IR, got better. Adipose-IR got better. CRP got better. So it's interesting. I don't think that we really, showed, there's clearly no change in hepatic fat in that short time in a eucaloric study where we don't drop the calories, but they did have these nice improvements in things that might speak to long-term cardiovascular risk. And so we will be following this up with future studies. Okay, so you heard a very nice explanation of a lot of the mechanisms that we're interested in from Dr. McLean, so I'm not going to go through this except to show you this part here. So fructose going through the microbiome, it may increase endotoxin. And so we looked at endotoxin in these same studies. And here on the top line is obese subjects, and then just beside them in the darker bar is obese subjects with steatosis in their liver. And these happen to all be Hispanic adolescents. And you can see that the endotoxin is significantly higher in those with steatosis. This is plasma TNF-alpha, and this is MCP1. So all elevated compared, although this one didn't reach statistical significance. So we also looked at endotoxin. Oh, I'm stuck. There we go. In our 24-hour study, because it may rise then after meals if your gut barriers are altered. And we did, in fact, see a big increase. So here's endotoxin with the arrow pointing towards it, and it's significantly higher at several of the time points that are at like after breakfast, after lunch. And the top line is the fructose drinks being given to the children, and this one is glucose drinks. So in the NAFLD kids, which is the dotted line, there still is some increase in endotoxin after meals, but it was much greater with the fructose drinks compared to the glucose drinks. And that's a very acute influence. And so I think this is, again, something that's very interesting, and we'll be following up more. Okay, and then endotoxin after 4 weeks. So remember, we looked at those kids for 4 weeks of fructose drinks and glucose drinks. And again, endotoxin going up with fructose, but no change with glucose. I was hoping for an improvement in the glucose drinks group, which we didn't see, but certainly there's a worsening in the fructose ones. So one last comment to kind of put together the idea of a maternal influence together with this influence on the children. So this is high fructose corn syrup, and so this is a shorter timeline here, so 1970 to 2008 across the bottom. But if you think about it, somebody who is currently 55 would have had very little exposure, none, to high fructose corn syrup in their infancy and childhood. Their mother wouldn't have been exposed to it, and not as much sugar, if you remember the sugar curve. But one of my patients was born, like if somebody's 14 or 13 today, they were born at the peak, right? So and there wasn't as much known about this 14 years ago. So it's very possible that a lot of the mothers were consuming large amounts in addition to being insulin resistant from already being overweight. And then my poor kid gets pizza every day. No, I'm kidding. So, but you can see it's really worrisome for this current generation. And so we'll have to see what happens over the next 10, 20, 30 years. But I hope that we're at the peak of this disease and that over the next 5, 10 years, because sugar-sweetened beverages have been decreasing, that we'll get back to this scenario where it's really not such a severe problem. So in conclusion, pediatric fatty liver disease is common and quite severe. Childhood exposure to fructose worsens inflammation, lipids, insulin sensitivity, but it doesn't look like we've shown an effect on hepatic fat at this point. Fructose reduction alone didn't improve the steatosis, and maternal exposures may predispose children to NAFLD, and so I think that's an important area of future research. Thank you.
Miriam, that was a really interesting talk. It made me think from a big picture about nutrient interactions with toxins, especially in children. I think about one thing that's been studied forever, I don't think there's anybody here talking about it, which is acetaminophen. It's a common hepatotoxic substance that has very safe, apparently, at lower doses. But I'm wondering, when you get with the situation we've talked about here with kids, whether the high fructose diet and obesity and all of these things are actually making kids potentially much more susceptible to other hepatotoxic substances that would, in normal kids or adults, not be a problem. Do you know of any research on that?
So that is a great question, and I think there's been very little done on it. And one of the problems is that we only know the tip of the iceberg on who has it and who doesn't. So I've had a couple of acute liver failure patients where they're overweight, and you wonder, like, if you could just know right away, do they have steatosis or don't they? I think it's very possible. So I think that stacking of injury is definitely possible. I don't know of any data on it.
Miriam, very enjoyable. The question I had to do with high fructose corn syrup as opposed to corn products. Of course, atrazine is a herbicide that is extensively used on corn production. And if I think about being a kid, we never had tacos, we never had corn products, and I don't know when atrazine was introduced. But so, what is the possibility that it isn't actually corn syrup per se?
Absolutely. So, and I think we've talked about this, but I think we should do metabolomics of the high fructose corn syrup, right? Or something where we look at, like, industry is extremely protective of the high fructose corn syrup. But when we were here, we tried to get some as a sample. But there has to be pollutants and things in that. But then, to your point, also in corn products. And so, I don't like to stereotype people's diets, but I do. there is a greater consumption of corn, like corn tortillas and corn chips, in my patients when I interview them. And so I think the Hispanic link may be partly genetic, but it also could be diet, possibly. And that has not been looked at well, and certainly not at the toxic level. And so I think that's one of the really nice things about being invited here to speak today, is that I hope that people will look at this using their toxicology knowledge.
One more question, Dave?
I just want to add a comment to that. The most hepatotoxic substance known to man, aflatoxins, are present in corn. And it's regulated in the FDA at low levels, but it's present in all the time in the diet, but at very low levels. But that's why I'm interested in this susceptibility thing, is whether these low levels that we think are innocuous, in fact, might not be under these kinds of circumstances.
And would it make it through the processing of high fructose corn syrup?
It certainly does in cornmeal and things like that, probably not in the corn syrup.
Gary,
Gary Williams, New York Medical College. You touched briefly on sex differences, and we've been studying that in rodents for a number of years, where at least in certain rat strains, there's a profound sexual dimorphism in liver function that arises with puberty. And I'm just wondering, are there good studies in pediatric populations of changes in drug metabolism over the course of puberty?
No, very, very little is done. There's a longitudinal study looking at puberty and the metabolism over puberty and insulin resistance primarily, but those kinds of 5-7 year longitudinal studies where they really dive into the physiology really haven't been done. But we're proposing something, so in a new grant, that we will be collecting samples through that critical time period. So, collaboration would be very interesting.
I think to keep on time, we better move along. Our next